The topic of this webinar are viral-associated fungal infections with a particular focus on COVID-19 and influenza. My name is Martin Hoenigl. I'm an associate professor for translational mycology at the Medical University of Graz Division of Infectious Diseases in Austria. So, what we've learned over the last decades is that whenever disaster strikes, fungi become prominent and take over control. And this has been true for tsunamis, earthquakes, war, where fungi can complicate war injuries, hurricanes, tornadoes, and most recently also the viral pandemic, COVID-19 pandemic, that resulted in a very large number of COVID-19 patients ending up in our ICUs and dying. So what happens during these emergencies is that these fungal pathogens add on insult to injury and cause severe superinfections in these patients suffering from underlying viral diseases and are associated with death in very high proportions. This has been described also in the two editorials offered by me in two journals in recent years. When we look into the timeline of COVID-19 emerging in late 2019 and then really hitting the world in 2020 and 2021, and overlay this with the timeline of fungal infections complicating COVID-19, then we see here in purple for COVID-associated pulmonary aspergillosis that there is a big overlap. We've really the first cases of COVID-associated pulmonary aspergillosis, or kappa, occurring very early during the pandemic and then continuously throughout the COVID-19 pandemic. In contrast, if we look into mucormycosis, here in orange, COVID-associated mucormycosis, we see a certain delay with only isolated cases occurring during the first year or so of COVID, and really many more cases then occurring during the Delta wave towards the end of 2020 and in 2021. Particularly driven by a very large outbreak with hundreds of thousands of patients in India. And then, when observing COVID-associated candidiasis here in dark green, it becomes clear that again, this really happened throughout the pandemic and really started early on after initiation, after the COVID pandemic hit the world. When we talk about COVID-19 associated fungal infections and secondary fungal infections, it becomes clear that there are two major groups of risk factors for COVID-19 patients, severe COVID-19 patients who end up in the ICU to develop these fungal superinfections. On the one hand, we have the clinical risk factors, and these are mostly well-known risk factors for fungal infections, which includes treatment with systemic corticosteroids, tocilizumab as anti-IL-6 treatment. Both of them are often used, for example, for treating severe COVID-19 in the ICU. Mechanical ventilation, of course, that is needed in these patients with acute respiratory failure. The lung injury caused by the virus itself. Long ICU stays that are often associated with the virus, and simple venous catheters and ECMO that may also be required in large proportions of these patients, as well as broad-spectrum antibiotics that may help to prevent bacterial superinfections, but may predispose these patients even more to develop fungal superinfections. On the other hand, however, and this makes this topic particularly promising and interesting, that is the fact that there are specific immunological mechanisms that predispose patients with COVID-19 associated acute respiratory failure to develop either aspergillosis or mucormycosis. And I will get into that in more detail during my presentation. Starting off with Aspergillus and COVID-associated aspergillosis as well as influenza-associated aspergillosis. Because really many of the things we've learned from COVID are also true for patients with influenza, which now start increasingly to populate our intensive care units. That's definitely there's definitely some overlap, although there are also some important differences which I will highlight. So starting off with COVID-associated pulmonary aspergillosis and their immunological mechanisms. So we now learned that SARS-CoV-2 infects the alveolar cells, alveolar epithelial cells, by binding to this ACE2 receptor. And there, the virus really represses the type 1 interferon response by blocking the transcription of interferon-stimulated genes. What also happens is that type 1 interferon autoantibodies, which are also produced during the viral infection, add further insult to this effect and prevent signaling through the IF and AR12 receptor. All these mechanisms result really in a delayed type 1 interferon response, which then in turn favors the release of pro-inflammatory cytokines and chemokines, which result in the recruitment of monocyte-derived macrophages and neutrophils that then further contribute to the cytokine and chemokine production, really ultimately resulting in this hyperinflammatory state and general dysregulation that is also called cytokine storm, and that really favors the development of fungal co-infections by causing this epithelial damage and making it possible for the fungi to invade the epithelial and the tissue, and then at the end also the blood vessels, and also of course by misleading the immune response and leaving basically a gap for fungi to grow and prosper. We have learned now even more about the mechanisms behind viral-associated pulmonary aspergillosis, and this study really focused on COVID and influenza patients, identifying many of the pathways that were identified for COVID are also true for influenza patients. So they identified authors here from Belgium, from Leuven University, Simon Faes and colleagues, including Joost Wouters, really identified a 4-level breach of antifungal immunity occurring during severe viral infection, severe COVID or severe influenza. First of all, there's the downregulation of numerous genes with antifungal effector function in patients with viral-associated pulmonary aspergillosis, which really implicates impairments in macrophages, monocytes, and neutrophils. And this has been shown also specifically for patients with aspergillosis, which had significantly lower neutrophil cell fractions than patients who only had COVID-19, but not aspergillosis. Second, SARS-CoV-2 virus induced epithelial barrier disruption, which really facilitates tissue-invasive kappa, as I mentioned before. Third, the downregulated interferon gamma signaling, which I outlined before, was observed in patients with viral-associated pulmonary aspergillosis compared to patients who only had influenza COVID-19. Well, there were not so many differences in concentration of other major cytokines. So really this interferon gamma pathway seems to be playing a major role. And then last, but also very importantly, the concentrations of several profibrotic growth factors were significantly increased in patients with viral-associated pulmonary aspergillosis versus those with only influenza or only COVID in the ICUs, really likely contributing to the higher mortality we are observing in these patients with fungal superinfections versus those with monoinfections. And there has been a more recent, also very intriguing paper in Science Translational Medicine by Sarden and al. That also identified another mechanism that may explain the risk for invasive aspergillosis during influenza A or COVID-19, and also it may explain the risk following corticosteroid treatment. So really it may explain the risk for aspergillosis in large proportions of our ICU patients. And they basically performed multiple models, including mouse models, where they were able to show that influenza and COVID-19 trigger the decrease in circulating anti-Aspergillus IgG antibodies and thereby impair resistance to Aspergillus in vivo. So this is a completely different mechanism, which is more triggered over the B cells, and really a very new groundbreaking finding. So what they identified is that specifically the SARS-CoV-2 spike protein triggers the B1 alpha apoptosis, so the apoptosis of these B cells, which then in turn leads to depletion of anti-Aspergillus fumigatus IgG, and thereby allowing Aspergillosis to remain concealed from recruited lung neutrophils, really leaving the door open for fungal termination and then tissue invasion and infection. And the findings of this study are also summarized by an article I submitted with two colleagues from France, from Pierre Gagnon and Papon, Nicolas Papon. I think this figure is helpful for outlining the immunological mechanism that was described here. So when going back to Aspergillosis and now to clinical diagnosis of Aspergillosis, we are facing a diagnostic dilemma, because diagnosis is so difficult because the disease may really be very different depending on the host and depending on the immunosuppression of the host. And this is shown here in the spectrum of Aspergillosis, where really in blue the amount of immunosuppression, or in red, the amount of immunosuppression, basically, the more immunosuppressed patients become, the more invasive Aspergillosis grows. And at the far end here, we have the neutropenic patients, the patients with prolonged absolute neutropenia, where we really have this acute invasive disease, where within hours, the Aspergillosis is able to grow through the tissue, through the lungs, into the blood vessels, disseminate to other organs, and can cause death very rapidly. Versus in non-neutropenic patients that have normal counts of neutropenia, but have other predisposing conditions, including severe respiratory viral disease or receiving systemic corticosteroids. So this is really applying to many of our patients at risk in intensive care units. They are a little bit up the spectrum. They're also immunocompromised, but not as much as neutropenic patients. So what we are seeing here is that first Aspergillosis invades the lung tissue, and there it really remains for days and grows for days until after some days, maybe 8 to 10 days, growth into the lung tissue as a tissue invasive infection. Finally, it breaks into the blood vessels, where it then quickly disseminates and causes, traumatic infection with very high mortality rates. And the unfortunate situation here is, if you really wait for Aspergillosis to break into the blood vessels, and even if we initiate then appropriate treatment right away, 80 to 90% of these patients won't survive this infection. So we really need to diagnose as early as possible, which requires us to go for this viral-associated pulmonary Aspergillosis into the lungs, do a bronchoalveolar lavage, for example, in these patients early on, to really identify that the fungus, while it's only growing tissue invasive and not yet ango-invasive. So this has important implication, of course, for the biomarkers, which we need to test in the BL and not wait for them to become positive in blood, including the biomarker galactomannan, which is the most important biomarker for diagnosing Aspergillosis. Of course, it has also implications on the radiologic appearance, because the typical radiologic appearance of Aspergillosis really only occurs in these neutropenic hosts, where there's this halo sign, for example, or the air question sign. But in these non-neutropenic patients, really there's no significant or no really typical radiological presentation of Aspergillosis. Mostly it's unspecific infiltrates. So radiology doesn't really add much to diagnosis in these patients. And this has been also shown by this study conducted by colleagues from Korea with cases from around the world. So these colleagues reviewed chest computed tomography findings from 35 patients with COVID-associated pulmonary Aspergillosis, and in addition performed a literature review on another 89 patients with COVID-associated pulmonary Aspergillosis. And at the end, they really identified that COVID-associated pulmonary Aspergillosis, or kappa, frequently manifests as COVID-19 pneumonia without common CT abnormalities of pulmonary Aspergillosis. So really, in the vast majority of these patients, no significant or specific typical signs, radiological signs of Aspergillosis, which makes, of course, diagnosis even harder. And all these difficulties in diagnosis have led, especially in the beginning of the COVID pandemic, to a wide range, a wide variation of reported numbers of COVID-associated pulmonary aspergillosis cases in COVID-19 patients, or specifically in COVID-19 patients in the ICU or on mechanical ventilation. You can see here, for example, in ICU patients, rates between 2.5% and 39% were reported in the early stages. And this was also due to the fact that at this time, we did not have good definitions on how kappa could be defined. However, of course, we've made some progress since then, and we are in a better state now, and I'll come to that in 1 or 2 slides. What's important is that I showed you up in the early phases, in the early stages of COVID, up to 40% of ICU patients with COVID-19 were reported to also develop COVID-associated pulmonary aspergillosis. And this really stood into some contrast to some findings from autopsy studies, where, for example, in this review, so this is not really an autopsy study, but really a review of a large number of mostly cases or some small case series published in literature reporting on autopsies in COVID-19 patients. A total of 677 dissidents were included in this study, but they really found, reviewing this literature, that only about 2% of these people who died from COVID-19 did have evidence of invasive mold disease, including aspergillosis. So the vast majority of this mold disease was aspergillosis. However, it's important when interpreting this data that, it's a great study, an important study, but there are limitations to it. And as a matter of fact, even when performing an autopsy and when you're not looking specifically for finding aspergillus, you won't find it. You need fungal staining usually in autopsy to be able to identify aspergillosis in these patients. And you also, of course, need a full autopsy. And many of these case reports were only a minimally invasive autopsy, where basically by random some needle biopsies were obtained. And there's another study, I think, that's smaller, so that has the limitation that's smaller, but it's single center and methodologically very well performed. In Italy, 45 consecutive autopsies, so really everyone who died of COVID-19 or died with COVID-19 in this study received an autopsy. Routine fungal staining of lung tissue was performed in 100% of these patients. And indeed, in this study, they found that 20% of cases had autopsy-proven aspergillosis, so 9 out of 45, which really matched the numbers that were identified clinically in this cohort. As I mentioned, we do have now better definitions for defining COVID-associated pulmonary aspergillosis, published by Köhl et al. Under, really a collaboration of many leading societies in the field, including the European Confederation of Medical Mycology, the ESCMID, and the ISHAM, which is really a worldwide organization for fungal infections. And there was an independent evaluation of these new criteria for classifying disease, and it really found that when compared to all the definitions of COVID-associated pulmonary aspergillosis, these new definitions brought down the prevalence of COVID-associated pulmonary aspergillosis to about 12% in this study, from originally 19%, which here in this cohort matched better the rate that was found by autopsies. So what are these definitions based on? They are strongly based on microbiological evidence, so on findings in BL fluid from patients with severe COVID-19 in the ICU. But of course, we also require that a patient has some suspicious imaging findings of at least infiltrates that could hide basically Aspergillus, and then also some clinical features in order to that a patient is not getting better, right? So we expect COVID-associated pulmonary aspergillosis to occur in patients who are getting worse clinically and not better. And what's important here is that there's not only the pulmonary form of COVID-associated pulmonary aspergillosis, but there's also the tracheobronchial form, the Aspergillus tracheitis, or tracheobronchitis, that is also a dangerous disease, also associated with very high mortality rates. And the good news about this disease is that this really can be identified via visual inspection, or at least suspicion can be raised via visual inspection of the trachea while doing the bronchoscopy in your patient, and then of course via biopsy or swabs you can basically detect the fungal pathogen. Going a little bit more into influenza and the differences in Aspergillus tracheobronchitis between COVID and influenza. First of all, it's really a form of aspergillosis that occurs in both of these patient groups. So Aspergillus tracheobronchitis occurs in patients with severe COVID and in severe influenza. But what is thought that there is, common mechanisms that predispose these patients from these two groups of viral infections to this disease. But then there's also differences, and particularly also dalmivir treatment may be an important factor that even more predisposes patients with influenza to developing Aspergillus tracheobronchitis. So that may definitely be an important factor that may play a role there, and also trigger earlier angle invasion in these patients due to NADPH oxidase complex suppression compared to patients with COVID-19. So there seems to be earlier angle invasions in patients with influenza compared to COVID-19. This is an important message for us clinically in order to manage these patients. In terms of diagnostic, going back to COVID, but same is true also for influenza, although to a little bit more limited extent, because as I told you, in influenza we have earlier angle invasion, so we have a higher likelihood of serum markers like serum galactomannan resulting positive. But generally said, for both diseases, COVID and influenza, we need material from the lower respiratory tract, preferably a bronchoalveolar lavage. If that's not possible, we also take non-targeted bronchial lavages, and really literally any material from the respiratory tract is better than just waiting for blood or searching in blood. So depending on your setting, we do want to get into the lower respiratory tract as good as possible, but even if you don't have this sample available, for example, because you're sitting in a place where no bronchoscopies are performed, you should test samples more from the upper respiratory tract, and they will still perform better than serum or blood for identifying Aspergillus. We do also have, and that's good news for some of the low and middle income countries, we do have now point of care tests available, like this Aspergillus point of care test, the lateral flow assay. There's also a second, a little bit more user-friendly assay, the LFT assay. But the LFA assay I show you here seems to perform particularly well. It can be performed for single sample testing, even in rudimentary laboratories. For detecting Aspergillus in BAL or also in serum. And we have evaluated specifically this test also for COVID-associated pulmonary aspergillosis together with Louis White and Jean-Pierre Gagneux and teams in a large cohort of patients with and without COVID-associated pulmonary aspergillosis. And we really found that this lateral flow assay performed well in respiratory specimens and comparable well to BL galactomannan and respiratory specimen galactomannan for diagnosing COVID-associated pulmonary aspergillosis, while similar to other serum markers, it did not perform well in serum for this specific disease due to the fact that I mentioned before that angle invasion really happens late and not early during the disease. So when observing the geographical distribution of COVID-associated pulmonary aspergillosis here from our Nature Microbiology paper, you can clearly see that the most reports, and this is really based on literature reports, occurred from Europe, because that's where COVID hit first and very hard. So basically, really the first, and when it was still a novel disease, lots of reports came out from Europe. But you will definitely see that this is purple around the world. So it also occurred to a similar extent in other places around the world. It's just that, because, for example, in the US, COVID hit, generally, it was different in some states like New York, but generally the big COVID wave came a little bit later in many places. So that Also, the reports were a little bit delayed in the US compared to Europe, and that's why we have fewer reports, although some of these reports, although they are small dot here, comprise a huge number of patients. So what we can say from the maps is definitely, COVID-associated pulmonary aspergillosis has occurred worldwide. Wherever you had COVID patients in your ICUs, you had patients with COVID-19 associated pulmonary aspergillosis, although your ability to diagnose it, of course, may have differed depending on where in the world you practice. One multi-center study, and we are in the lucky position that we do have now some large multi-center studies on COVID-associated pulmonary aspergillosis. So in this cohort study, a total of nearly 600 patients with COVID-19 ICUs, mostly hospitalized throughout Europe, were included. And of those, 108 patients developed COVID-associated pulmonary aspergillosis. And when really going into the centers that performed this cohort study, the median incidence was slightly below 11%, so slightly more than 1 out of 10 patients with COVID-19 in the ICU developed COVID-associated pulmonary aspergillosis. But again, here between the centers, the range was quite significant. And we also have another multi-center study here, specifically from France, with 18 French ICUs participating. These were all patients that were specifically screened and tested for COVID-associated pulmonary aspergillosis, which really contributed to this higher rate of about 15%, so 14.9% of patients in this multi-center study developed COVID-associated pulmonary aspergillosis. We really end up now with estimates of 10 to 15% of cases in our ICUs with COVID-19 developed COVID-associated pulmonary aspergillosis. Risk factors were also outlined here. Older age, combination of dexamethasone and anti-IL-6 treatment, so tocilizumab played a major role. Further outlining the risk factors that were observed in multiple studies on COVID-19 associated pulmonary aspergillosis, it becomes clear that really the findings of this French study are also applicable to most other studies that were performed in this field. So really dexamethasone, tocilizumab, and their combination seems to be a major clinical risk factor for developing COVID-associated pulmonary aspergillosis. But of course, there's also multiple other risk factors that may play a role here, that may relate to underlying diseases in these patients. Also, some factors on antibiotic treatment in these patients. And of course, last but not least, always important to highlight environmental exposure in your ICU. So if you have aspergillospores in your ICU, you will observe higher rates of COVID-associated pulmonary aspergillosis. What's important, and this really gets back to diagnosis in its implications, is the prognostic potential of diagnostic test results in patients with COVID-associated pulmonary aspergillosis. And this is really going away from any disease definition. So this is really just basically calculating in a large cohort of patients what is the independent association with 90-day mortality for different diagnostic tests for aspergillosis that result positive. And here in this study, led by Daniele Giacobo, also a sub-analysis of the ECMM Kappa study, led by my colleague Jürgen Brattes and myself, the multi-center European study I showed you before. Basically, the combination of a positive BL fluid galactomannan with a positive BL fluid aspergillus culture was an independent predictor of mortality in COVID-19 ICU patients with a hazard ratio of 2.53. And this really adjusted for all other common known or described factors that predict mortality in COVID-19 ICU patients. So you see this strong contribution of COVID-associated pulmonary aspergillosis to mortality in these patients. The other independent predictors of 90-day mortality in this cohort were increasing age and active malignant disease. So that's basically how important COVID-associated pulmonary aspergillosis is. So really, I think, very important data, and you can see even, compared to active malignant disease, having kappa is something, or having, these two diagnostic tests positive for kappa is associated with higher risks of dying than having an active malignant disease. And that's not the only study. There's also other studies. Here, a study from the Netherlands that looked into, multi-center, mostly Netherlands, but also a few French centers participating, that really showed that positive serum galactomannan and beta-D-glucan were particularly associated with increased mortality compared to patients with COVID-associated pulmonary aspergillosis who had negative serum biomarkers. And I think that's striking and has a lot of implications for us because in those patients who already had a positive biomarker for aspergillosis in serum, like galactomannan, nearly 90% died, the fatal outcome, despite appropriate antifungal therapy. So this clearly shows us that we can't rely on serum markers and then serum testing for diagnosing COVID-associated pulmonary aspergillosis. We need BL testing and we need to go into the lungs. Overall, the mortality here was 54% in patients who developed COVID-associated pulmonary aspergillosis versus 24% in patients with COVID-19 who did not develop COVID-associated pulmonary aspergillosis, showing you this big contribution of aspergillosis to mortality. And we also have another study basically finding the same but in a different large cohort. Here, positive direct examination of BL or plasma qPCR and serum galactomannan were associated with a close to 100% mortality rate. So once you have detection of aspergillus in blood, unfortunately, in your patient, this means that there's an extremely high likelihood that your patient will not survive this infection and will die despite optimal treatment. So that's why we can't rely on serum testing or blood testing for diagnosing viral-associated aspergillosis. There's, of course, other large studies looking into mortality of kappa, and I think luckily it's a little bit boring because they all found the same. Here, a first study of 186 kappa cases, again, a mortality rate of 52.2% in these patients with kappa, so significantly higher than we're generally observing in ICU patients with COVID-19. Here, a cohort study that went into further detail, really evaluating COVID-associated pulmonary aspergillosis as an independent predictor of survival in COVID-19 ICU patients, even after adjusting for all these other risk factors like older age, like malignancies, etc. And here it becomes also very clear that kappa by itself is a very strong independent prognostic marker in COVID-19 ICU patients. As a result, of course, given that kappa causes mortality and causes such high rates of mortality, it's now clearly, there's a clear consensus now that we do need early antifungal treatment in patients with COVID-associated pulmonary aspergillosis and also, of course, with influenza-associated pulmonary aspergillosis. First-line treatment is recommended with voriconazole or isovuconazole, with really liposomal amphotericin B being the first alternative if for some reason we can't use an azole in these patients or if patients are not responding well to azole therapy. We are lucky currently to live in the times we live in because after 2 decades where no new antifungal class was approved or became available for clinical use, now we have a number of new antifungals, including new antifungal classes that are in a late stage pipeline of clinical development. And these may all be very promising candidates for treating aspergillosis and also specifically viral-associated pulmonary aspergillosis in the future. So to mention some of these drugs, fosmanogepix and olorofim, both completely new antifungal classes that may be very effective against aspergillus without the same burden of drug-drug interactions and toxicity. Rizafantin and ibrexafungerp. Rizafantin is an echinocandin, so not a new class, but a new drug that has a very long half-life and really enables us to give it only once weekly versus daily via infusion. And ibrexafungerp is a new antifungal class that has kind of like a close to similar mechanism of action to echinocandins, but still different, which is important in terms of resistance. And both of them may be used in antifungal combination also against aspergillus. And particularly exciting is, of course, the fact that we do have now an inhaled azole, opelconazole, that has been developed particularly in terms of its particular size for inhaled use, so it gets into the peripheral alveoli and may allow inhalative treatment of COVID viral-associated pulmonary aspergillosis if combined with a systemic agent, because this oplaconazole really only is effective in the lung, which is also a good sign because it does not cause systemic side effects or drug interactions, but you need a systemic agent as an add-on for treating the systemic part of the disease. So this really brings me to the next COVID-associated fungal infection, mucormycosis. And for mucormycosis, we also have a number of important immunological mechanisms that predispose patients with COVID-19 to develop COVID-associated mucormycosis. And I really have to thank Ashraf Ibrahim for lots of these findings, together with Agostino Carvalho, who contributed all this knowledge to our Nature Microbiology paper. So first of all, we do have hyperglycemia, and then in COVID-19 we also have had at some point some steroid overuse, which really contribute together with high levels of iron and ketone bodies to the expression of GRP78, which by itself then serves as an important cofactor in viral entry and binds to spore coating COTH3 invasine on the fungal surface, which then favors the invasion of nasal cells by Mucorales. So this really predisposes these mechanisms to one clinical form we are seeing for mucormycosis, which is the sino-orbital form, sino-nasal orbital form, and sometimes cerebral form of mucormycosis by favoring this tissue invasion of Mucorales through the nasal epithelial cells. Importantly, there's also an interaction of COTH7 with integrin alpha-3 beta-1 in alveolar epithelial cells, which then, of course, in the lung contributes to the progression of pulmonary mucormycosis, which is another clinical manifestation of mucormycosis we are observing. And last but not least, the production of mucorecin by Mucorales hyphae promotes vascular damage that allows the enhanced recruitment of leukocytes from the bloodstream into the tissue, again causing this hyperinflammatory state. In terms of worldwide epidemiology, when looking into the map, it becomes also clear that COVID-associated mucormycosis is occurring worldwide. However, it has to be emphasized that in many countries of the world, this is only a few cases, like in the US, in most parts of Europe. We are seeing these diseases. We saw it at my institution, but it's usually rare. It's some cases, it's 1 or 2 cases per year, maybe 5 cases a year, depending on the size of your institution, that is observed. However, the story is different for some other parts of the world, particularly for India, but also there's reports of large numbers of cases, for example, from Egypt, from Pakistan, from Iran, also some, very intriguing numbers from China on rates of COVID-associated mucormycosis there. Always important to emphasize is, of course, described cases does not always mean actual cases, because also mucormycosis is very hard to diagnose. And in many parts of the world, it's just impossible to diagnose many clinical manifestations of mucormycosis. Zooming in further on India, because that's how COVID-associated mucormycosis really came to our attention as the cause of this black fungus pandemic that went through all media, causing many more than 100,000 infections, probably more than 200,000 infections in India. And we always had a high number of mucormycosis in India, even before COVID-19, which is due to the fact that there's a lot of environmental exposure to mucormycosis in India, starting off from farm working, rural communities, but also in the cities, and particularly the central air condition system, which is in place in Indian metropolitans and cities, may be contributing to this exposure to Mucorales that is constant in India. However, what was shown that during COVID-19, and you see here the direct comparison between 2019 and 2020, that the number of cases, which was always high, again doubled basically during the COVID pandemic. So really outlining the contribution COVID had on the number of mucormycosis cases in India. And zooming in further into the details, why we think and explanations why we think this happened in India, I think, first of all, we do have the environmental exposure, but we did have this before. But this is a constant factor that, of course, contributes to the the fact that mucormycosis had such a devastating impact in India. And then, and that's really something that came in specifically during COVID, we had a higher number of susceptible hosts. So everybody is exposed in India, but then suddenly we had a higher number of patients or people who could not just, where the immune system was not able to fight the mucor, but really mucor was able to invade the immune system, invade the tissue, and cause invasive fungal infection. And contributing factors there were, first of all, the steroid use and also the steroid overuse that happened in India during the Delta wave, due to the fact that there was not enough oxygen supplies available. So not enough oxygen supplies, not enough ICU beds with mechanical ventilation, but corticosteroids were available for everyone to buy over the counter. So the desperate Indian population, many of the sick people just were desperate in buying a lot of corticosteroids and a lot of dexamethasone and taking too much dexamethasone actually, and overdosing dexamethasone, really contributing to the risk to develop mucormycosis, contributing to the iron overload, which also was basically triggered by an increased number of patients with newly diagnosed diabetes mellitus with diabetes mellitus that was undiagnosed or not well controlled. And why did this happen in COVID-19, especially during the later stage of 2020, so during the Delta wave? You know that the health systems basically were reduced. Routine care for people was reduced, and this was also true for India. So new diabetes was rarely diagnosed, was fewer diagnosed, and there was a delay in diagnosis of new diabetes, and there was also the lack of control of diabetes in many patients, leading to a higher number of uncontrolled diabetes, higher number of non-diagnosed diabetes, and thereby contributing to an environment that was highly susceptible to develop mucormycosis. And finally, there's also some indications that the virus itself may mediate exocrine damage, further contributing to hyperglycemia and thereby contributing to mucormycosis development. In one of the very early stage studies basically published or accepted in early 2021, we looked into cases of COVID-associated mucormycosis worldwide, and by then it was still not reported very much, although it had occurred in much more patients, but the reports at that time point were only the tip of the iceberg. And we found this interesting difference where in India, really, reno-orbital cerebral mucormycosis accounted for over 90% of patients, while in Europe and the US, the pulmonary disseminated form of the disease accounted for 50% of COVID-associated mucormycosis cases. And going further into the question, why do we observe this difference and why do we so rarely see pulmonary or disseminated disease in India? This really has to do with the difficulties to diagnose pulmonary and disseminated disease. And this is really, not something I'm saying coming from Austria, but it's really something that, my colleagues from India are confirming that it's nearly impossible for them to diagnose pulmonary or gastrointestinal or disseminated mucormycosis, at least the vast majority of these diseases, because they are not performing bronchoscopy so often, etc. So, given that, an important part of the disease entity and the disease prevalence cannot be diagnosed in many places like India, you can of course argue that probably these 100,000 or 200 cases of COVID-associated mucormycosis are still a severe underestimate. In terms of diagnosis, we do have some breakthroughs now for mucormycosis, with mucor-PCR being now more broadly available, which may also help to diagnose this infection in blood specimens. And in terms of treatment, of course, we do have some specific guidances by the ECMM and ISHAM. We have the One World, One Guideline initiative that really recommends liposomal amphotericin B as first-line treatment for mucormycosis. while we also have some specific guidance for India and other low and middle income countries that goes into further detail, because of course you can imagine with these hundreds of thousands of mucormycosis cases, many of these antifungals were not available anymore. So this goes into the detailed recommendations based on what you should do if certain antifungals are not available, and really accounting for the desperate situations that India was facing at that time. Last but not least, a few words to COVID-associated Candida infections. Here, it has to be said that basically, of course, we are observing a high number of Candida infections in ICU patients with COVID-19, but this is not necessarily higher than the number we are observing of Candida infections in ICU patients in general, even before COVID-19. And going into immunological mechanisms, and really so far we can say there is of course some immune dysregulation, but none of these immune dysregulations caused by COVID-19 really seems to predispose patients particularly to develop Candida infections. And the major factors why some patients with COVID-19 develop Candida superinfections may really be clinical risk factors that occur in COVID-19 patients, but not specific immunological mechanisms or viral fungal pathogen interactions. In terms of outbreaks, of course, particularly Candida auris outbreaks, but also other Candida outbreaks have been described in COVID-19 patients. Candida auris is, of course, a bigger threat than some of the other Candida species because it can be transmitted via healthcare personnel from patient to patient and can cause these large ICU outbreaks. In terms of the worldwide epidemiology, going back to our Nature microbiology review, you see that COVID-associated Candida infections occurred worldwide and are really, described from most places around the world. In terms of risk factors, as said, these are really the known risk factors that predispose COVID-19 patients to develop Candida infections, prolonged ICU stay, central venous catheters, higher age, more severe disease, higher organ failure score, assessment score, higher SOFR score, then corticosteroids, tocilizumab as immunosuppressive treatments. For Candida auris, also prior antifungal exposure that may play a role. But these are all basically known risk factors for developing Candida infections and not different in COVID patients versus other ICU patients. In terms of future treatment options for Candida-associated COVID-associated candidiasis, we have to emphasize that, of course, we do have now echinocandins as the first-line treatment for invasive Candida infections in our ICUs. In the future, we do have, as mentioned before, rizafantin and ibrexafungerp that have, a similar or, not so different mode of action, mechanism of action. And then we also have fosmanogepix. All of them have a broad spectrum against Candida, including resistant Candida species like Candida auris. And this really brings me to my take-home messages for kappa first. So we really have immunological and clinical predisposition that may explain the high rates of COVID-associated pulmonary aspergillosis in patients with COVID-19 on mechanical ventilation. As mentioned before, 10 to 15 to maybe 20% in some studies on average. Then we do have the major clinical risk factors which relate to the treatment of COVID-19, tocilizumab and dexamethasone, which of course is needed for treating COVID-19. So it's not basically analyzed here. There is no studies that show that we should not give these treatments to COVID-19 patients in the ICUs because it's life-saving treatments for COVID-19 there. At the same time, we do have to be very vigilant and for potential fungal superinfections. Other risk factors, older age and mechanical ventilation. Mortality of COVID-associated pulmonary aspergillosis is very high, over 50%, despite appropriate treatment. And really, kappa by itself is independently associated with mortality. We need to diagnose and treat early with either voriconazole, isobuconazole, or liposomal amphotericin B. Prophylaxis for kappa is something that some smaller studies are looking into. It's mostly single-center studies that found a good effect of giving antifungal prophylaxis with an azole. However, we need a larger multi-center study or randomized controlled trial to really, know whether antifungal prophylaxis will be indicated in these patients. And moving on to mucormycosis and candidiasis. For mucormycosis, there's a clear immunological but also clinical predisposition for COVID-19 ICU patients and severe COVID-19 patients to develop mucormycosis. Particularly in India, over 90% of mucormycosis cases there are the reno-orbital cerebral form, while in outside India, about 50% of patients present with pulmonary mucormycosis. And last but not least, for Candida, it's really here clinical predisposition. That is the main reason that we are seeing Candida infections in COVID-19 patients. And with that, I want to thank you for your attention.